Morning, everyone. Since this is the first grand rounds of the year, Happy New Year to everyone. I hope this year has gotten off to a good start for all of you. This morning we have two excellent talks. The first one is pharmacogenomics-based clinical care at the University of Colorado Medical Campus. And, you know, as clinicians, when we see a patient or a patient with a disease, we tend to hit them with the same hammer. But what this type of work will allow us to do is to really fine-tune things and to really make sure that we use all the tools available to us, all the different pharmacologic therapies and other therapies available. The two presenters this morning are Dr. Christina Aquilante and Dr. David Kao. And I'm told this morning Dr. David Kao will give the presentation. But Dr. Aquilante is a professor of pharmaceutical sciences in the Skaggs School of Pharmacy. She received her PharmD at UNC. Came to the Skaggs School of Pharmacy about 20 years ago and has really quickly risen through the ranks and has led many different programs on campus. She's extremely well published. I read through her CV, has mentored a gazillion students and postdoctoral fellows in various areas. Dr. David Kao is Associate Professor of Cardiology and the Medical Director for the Colorado Center for Personalized Medicine. And we were just talking and we share some common background. He did his undergraduate degree at Johns Hopkins in biomedical engineering, then went on to receive his MD also at Johns Hopkins, went across the country to Stanford to do his internal medicine residency, and then came here to do a cardiology fellowship. He joined our faculty in 2012, currently holds an active NHLBI R01 as principal investigator, is extremely well published, and also in reading through his CV has mentored and is mentoring a gazillion people. So Dr. Kao, we look forward to your presentation this morning. Thank you.
Thanks. This one? All right. Thank you, everyone, for the chance to speak with you today. We're looking forward to giving you an update about how our pharmacogenomics program is doing here at Colorado. I think you've heard a little bit of this before, but I'm just going to start at the beginning for the sake of level setting. So, there we go. Okay. All right. So what we're going to do is a little bit of high-level overview of the biobank and then talk about where we are with regards to implementation of pharmacogenomics here, specifically what we have returned, are returning, and how people are using it right now. And then kind of at the end, if any of that appeals to you, talk a little bit about how folks from this group can potentially access the biobank and participate in research that way, whether ongoing projects or your own. Okay, just as a reminder, the CCPM, or the Colorado Center for Personalized Medicine, is an ongoing partnership that's primarily between the university and UC Health, which has the goal of bringing together a number of different schools, disciplines, and expertise in order to really implement or deliver both knowledge and kind of expertise in incorporating genomic medicine or other types of precision medicine into clinical care, whether it's on an individual decision basis or sort of more at a population level. The centerpiece of CCPM and this discussion here is our biobank, our DNA biobank, which just sort of in terms of numbers and rank, we think we're about the fourth largest academic biobank and the sixth largest biobank of any kind in the US. You see the link there. We have enrolled or consented over 250,000 UC Health patients, collected samples from over 155,000 now. And of those, over 100,000 have had their DNA analyzed, and then over 73,000 now have pharmacogenomic results in their EPIC medical record. This has made us the nation leading, if not more than that, pharmacogenomics program in this country in terms of volume, scope, and impact. For those who haven't heard about how this works, the biobank is now a completely electronic or digital consent process through My Health Connect. There's a self-consent, so no provider has to worry about kind of counseling a patient through that. It's a page within My Health Connection that a patient can go to, read all the stuff, and then elect to participate if they would like. If they do, an order is generated so that the next time they have blood draw of any kind, there's a sample extra tube drawn for the biobank. That's then extracted and analyzed in a number of ways, both locally and at Regeneron. Locally is a sort of a microarray single nucleotide polymorphism platform, and Regeneron is doing our whole exome sequencing. Once we have those genetic results, we can send them back through for pretty novel pipeline into EPIC as what we call structured results. So those are not just free text, but results that you can do things like search on, trigger alerts on, query, create reports, all that kind of stuff. So we're actually sending all of our pharmacogenomic results back that way. When we do that, or after we do that, we sort of have two agendas with it. One is ongoing research, like epidemiology, outcomes of people with different variants. But most important to this group, I would say, is the clinical point of care delivery and implementation for shared decision-making with patients. This is just really for reference as much as anything. These are the pages within My Health Connection that will allow a patient to get to that self-consent. And after that, they really don't necessarily need to do anything more after consenting to have some level of participation, although we would love if they continue to kind of engage with us on an ongoing basis. So in terms of the clinical action or the clinical return results within the biobank so far, we're currently returning results for 12 genes. And you'll see it says preemptive return. What that means is that those results are put in the record whenever the assay is run, right? You're not waiting for something to happen. You write an order and then the result comes back sometime later. They go in as soon as we have the result and they sit there in the record until they're needed, really. So they're filed as discrete data. Again, that's data points where you can do things like trigger off a variant or a genotype. You can run certain kinds of reports without trying to read through or having to read through PDFs, free text, and that kind of thing. Anytime we release a new gene through this program, we include clinical decision support. So those are prompts or alerts or education of a number of different kinds so that a provider never actually has to know that the result has been returned. The information will be presented when you try to write the prescription that is relevant, or when the patient has the relevant genotype for that prescription. There's sometimes people worry about, well, what if I miss the result that's being filed, especially because you won't get an alert about it. And for this purpose, you actually don't have to worry about that at all. You just will receive a prompt when it becomes important. So right now for those 12 genes, we have 53 medications that have decision support that's written for them. And those are based on sort of expert consensus guidelines from CPIC. And then in general, alerts will either say this is why this is important for this patient in this situation, and sometimes will offer an alternative suggestion for an order. You can see the genes at the bottom, CYP2C19, the clopidogrel and related one, and a statin. Pharmacogene were the first ones from 2021, and now we've expanded considerably to include CYP2D6, sort of the mother of all pharmacogenes, as well as even the warfarin sort of profile of genes with calculators within EPIC that automatically interpret that sort of morass of warfarin-related pharmacogenomics to suggest doses. The patients all do receive a message when a result is filed for their genotype. There are educational links for them out to things that we have made and curate regularly. The providers can access all of that too. We have both provider and patient-facing education references that go anything from just the very basics. This is the drug that this affects to the full kind of pages around the guidelines that support what we're doing. So again, 12 genes for 53 medications presently, with our most recent set going live a couple of months ago. So we have enjoyed just really rapid growth within the PGX program. These are figures that indicate how many patients have had at least one result and how many results we have returned. You can see the pertinent numbers at the bottom. I mentioned the 73,000. There are over 630,000 individual PGX results now in EPIC that we generated. But the most important thing is the curve in the graph. It's not really a curve. It's more like a elbow shoulder thing. And we're scaling in several different ways. And so we've, in general, been able to achieve exponential growth a lot of the time since about 2022, early 2023. So we're just kind of getting going, to be honest. There we go. For those who are interested in the demographics, they're on the left. I won't read them to you, but the one on the right, I think, is really the most people say, does this matter? How often does this actually happen or come up? So in our research arm, we've gone back to look at how often people have a PGX related genotype that would affect prescribing, just within our population and within the panel that we have. And we found that 90% of our participants have at least one actionable pharmacogenotype, and 50% have at least two. So it's actually, for those who have had their DNA analyzed, it really has tremendous potential. There's more than likely you will end up on something that is going to be affected by your genotype. This is just kind of a couple shots of how to find these things. So I mentioned the decision support, which you don't need to do anything at all to find it. Just like most of them are not pop-up alerts. They're just like little messages in the order box that don't interrupt your flow at all. But if you wanted to go look for the results themselves, they do live under the lab tab. And if you just type PGX, they'll all come up. So that's true for either patients or providers. And then EPIC has recently kind of made this thing called the EPIC Genomics module, which has added some functionality that lets us organize genomic results better. They're called genomic indicators, so that's what EPIC calls their little data fields that include a lot more education information. They can be used for decision support stuff, and they can be organized to put all the genes in one place. And that could be biobank genes, that could be any kind of genetic result that's put into an indicator. Right now, most of the indicators are pharmacogenomics. So, but in any event, these are each line here is one gene, and there are a bunch of references and decision support and all that below. You can see these now under the history tab, under that snapshot deal, in the main navigator. We do anticipate this becoming a little more accessible in different parts and different of EPIC within the workflow, so you don't have to go hunt for it quite so much, but I think we're just getting to the point of having enough material that it sort of warrants a change like that. I mentioned 12 genes and 53 medications. For reference, these are, you saw the genes, these are the drugs that have come up or that we currently have decision support for this group, probably the NSAIDs, opiates, antiemetics are, I'm guessing, the most relevant or that you're most likely to encounter one of these decision support modules. But you can see there's all kinds of stuff from chemotherapy to PPIs and everything in between. So this is growing as we add new genes. We generally have all of the level A guidelines decision support ready when we release a new gene. So unless there's a new level A guideline, most of the medications are added with new genes. So we talked about how many people have relevant genotypes. Does it actually show up in clinical practice? That's maybe the most important thing. This is a graph which you can see visually looks pretty much the same as the other ones, but these show how many alerts have occurred during medication orders by UC Health providers. Of all the results, about over 17,000 have had an alert of those results. And that means over 12,000 patients have actually had at least one PGX alert just in the last couple, well, most of them are in the last couple of years. This definitely puts us at the top of PGX clinical implementation programs in this country, again, if not broader than that. Oops. So a lot of the patients, 17.5%, who have had a PGX result returned to their record have had that translate into at least one actual alert during prescribing. So that's, 20% is a pretty good hit rate, especially when you consider how many patients have an actionable PGX results. You can see our general breakdown with sort of PPIs being a lot of the alerts, then statins and SSRIs, and then down to clopidogrel being one of our high impact in terms of outcomes or the consequence of the wrong clinical action. 1.6 may not sound like a lot, but if you put it in the context of the number of alerts that we've had, it's actually a non-trivial number. So these are just examples of how the content will show up. Most of our alerts are these passive warnings. So when you order something, it just puts a little line at the top or a line at the bottom, wherever within each order that says there may be a poor metabolizer, consider changing the dose, right? So this isn't something that stops you, doesn't interrupt you, you don't have to click through it or anything. It's just there when you are going to order the dose. But then we do have some things where it is very important, and what we mean by that is that the outcome may be very serious. That's generally the case where we decide to use a pop-up alert. It is by far the minority of genes that have those. CYP2C19, clopidogrel is an example of one where the consequence is stent thrombosis and death if you do the wrong thing. So those are the types of things we reserve pop-up or interruptive alerts for. So does it work? When we show alerts, I would say yes. I think we do pretty well here. On the top, you have the percent of alerts associated with an action. So for those passive alerts, which again is the majority that we mentioned, up to a quarter of suggestions were followed or the right thing was done in statins. That may not seem like a lot, but in the literature, passive alert success is more like in the 5 to 10% range, if that, for those non-interruptive things. So this is actually really, really good. And then our interruptive alerts, so we have clopidogrel, voriconazole, and the fluoropyrimidines, which have very severe, if not fatal, potential outcomes. We have very high response rates for all of those alerts. And in fact, for the high-risk medications, at the end of the day, which means that if you go back a day later and say, was the right med prescribed, that has happened in every patient, or at least the right decision was made and the genotype was considered in the appropriate way. So obviously you can't get really better than that. The literature around active interruptive alerts suggests around 65, 70%, sometimes 80% success rate frequently. So obviously 100% is just tremendous. So all that stuff is ongoing, it's great, and it's expanding quite rapidly, both as a result of more patients, more assays, more genes, and more drugs. That will continue on, and it opens up a lot of opportunity for different kinds of research, whether it's, epidemiology, pop health, how often does this matter, and do the genotypes affect outcomes, mechanistic kind of things to say, are there novel or new associations that we can drill down on more? And then there are outcomes research projects that are possible, which we do with pharmacogenomics in terms of, does this improve outcomes? We're particularly interested in the last because of the drive to have payer reimbursement for this one day. We kind of think that improving clinical outcomes is going to be the centerpiece, or is going to be required for that. So we're very keen to have as many subject matter experts or different specialty groups kind of chime in to find where there are opportunities there. But that said, there are really, sky's the limit as far as ideas you might have. If you do want to kind of tap into the biobank and the PGX program, you can contact me for sure. There are kind of routes through the CCPM websites, but we'd absolutely love to have more and more collaborators throughout the school in order to make better use of this, because we managed to do a lot of this with a fairly compact or fairly small group of people. We're really at a point now where the more people, I think the more impact we can have, the better we can design these things to fit with what you do, so that you'd start to not even think about it, you just kind of expect it to be there. You see a pharmacogenomic result and you're like, oh yeah, I should do that. So I think the way we get there is by having engagement for as many different specialists as we can. So this is the, these are some of the sites to go request or propose research using the biobank data, or again, you can contact me or one of our other, Dr. Aquilante or other CCPM leadership. And if you're not quite there, you want to see a little bit more, and if all of this may fit into some of your own goals and objectives, you can also kind of join our CCPM membership program, which is really just kind of a formal way of being incorporated into the events that CCPM has, whether it's educational or otherwise. You can do anything from just show up at a seminar every now and then to be on a committee like what we're talking about in PGX. So offer the QR code there. Would love to have anybody who's interested line up. And then we just have some names here. I think we're right on time, so I'll pause there. I do want to acknowledge we have Anna Tanaka and Dr. Aquilante sitting here today. They're the real brains behind this whole operation and have really made it what it is today in terms of success. So it's been built from nothing to the best probably in the world, if not that, definitely in the US. And they're really sort of deserve all the credit for that. So happy to take any questions or come find us afterwards.
Who in the audience has seen one of these pop-ups regarding one of their patients when writing something? I'm surprised there are not more. So in cancer, obviously we see this a lot in terms of metabolism of the various drugs, chemotherapies, et cetera. I've seen it a couple times on my patients when I tried to, we try to prescribe a non-steroidal that's popped up or an antiplatelet medication. Questions or comments? Dr. McIntyre.
Change prescribing habits, but is there any way to analyze the population of patients who've been in the data bank versus the population of patients who are not, and what the incidence of adverse drug interactions or events are in those two populations to know how this affects clinical outcomes?
Yeah, that's something that Dr. Aquilante spends a lot of time thinking about, and I'll give a brief answer, and if you want to throw in anything. But in general, yes, the way that we can't randomize, obviously, you could do a case control, which is kind of fraught in a few different ways. What we have settled on for right now is historical cohort comparisons. So we have a historical cohort who we don't know anything about. We have historical cohorts where we know their genotype now, but they had their treatment before we knew their genotype. We have people now who don't have their genotype, and then we have people now who have a genotype whose care was changed. And we kind of think in terms of, did the alert matter? That the historical cohort between, people with a genotype now and an alert versus people in the past with a genotype but no alert is the closest, we think, to what you're trying to drill down on, which is, did this information change their outcome? It's not a perfect way to do it, but it's probably the best way we have given the structure of the biobank. We agree, though, we don't want to be doing, burdening people with this if it doesn't matter at all. So the accumulated events are slow enough, it's hard to do a prospective study that will give you feedback in any meaningful kind of time frame. So that's why we're doing this historical cohort.
Couldn't you look at, 5-FU is a commonly used chemotherapy. Before this, we were hurting and hospitalizing, not a lot, but a handful of patients. But since you've done this, my guess is a clinician sees, don't prescribe 5-FU because it's going to lead to disaster. They don't prescribe it. I mean, that's something you could easily look at, right? I mean,
yeah.
The key to these questions is for high impact meds, we need to accrue enough people in the biobank who have the at-risk genotype and have been prescribed the high-risk med. They tend to be lower frequency, so we just don't have the numbers to do the comparison, the formal comparison to the historical cohort quite yet. However, separate from the biobank, we do have a GI oncology pilot that's ongoing with preemptive genotype, not related to the biobank, but we're doing exactly what you just described. We're comparing the actions and outcomes in people that were tested versus a historical cohort that was generated from Health Data Compass. And so the answer to that is yes. But as Dave pointed out, we really do want to look at these outcomes for the high impact, really important examples. In the biobank, it's just going to take a little bit longer to accrue enough people so we have power to really find anything between the two groups. So,
yeah, and for the 5-FU DPYD kind of story, this is just anecdotally, but we've had pretty much every combination of things from de novo, never exposed with, an adverse genotype, who we dose reduced and then they tolerated therapy well. We've had people who didn't tolerate therapy in the past, which was never quite figured out. Turned out they were, a reduced metabolizer, and they had already known to dose reduce, but now they knew why it happened before, right? So there are a few different ways that it has showed up.
Marco, Dr. Del Chiaro.
Yeah, this is amazing. I saw some presentation, I think in one of our research retreat before. One of the question is, do you do you think it's possible to follow some cohort of patient longitudinally and trying to answer some unsolved question? I'll make you a typical example. As you know, there are some antihypertensive, like for example, ACE inhibitor, but many other drugs that has been in retrospective fashion associated with the chemo prevention, with, cancer prevention. Now, I don't believe has never been done really prospectively in a large cohort, especially with the gene profiling of those patients. And maybe there are patients in which there is an effect and maybe some other no. That's why there is a discrepancy in retrospective studies. So is this something that could potentially be applied to a population like this one? Because this is a huge population, very well studied.
Yeah, absolutely. I think the only barrier really is manpower, to be honest, and funding. But because the genotype is static, right? Even though we're only getting it later in life, you can look back to whatever point that you want, and we have, 6.7 million patients in EPIC now from, since 2011 when it went live. So there's certainly potential for that. Like I said, those are kind of ideas. If someone has them or wishes to kind of explore those, like, please let us know, because it's really just a matter of people saying, hey, can I look at this? It's not a lack of data or anything like that.
Who do research, who have a research as part of your distribution of effort. You can access the biobank, all of that genetic data, and you can answer non-PGX questions as well. Maybe you're interested in genetic associations with a disease or mainly disease, but you could also look at drug outcomes as well. And so all of that information in these slides about how to access resources, it's not just PGX, but it could certainly answer a question like you just proposed, but it could be disease related things that you might be interested in. And so really encourage folks to tap into the powerful research resources here on our campus. And the biobank just has a ton, and there's just lots of things that could really enhance and complement a research program. So please check out those resources.
Well, thank you very much for coming and presenting.
Thanks.
Thank you. Yeah. Great. Our next speaker is Dr. Rafael Malgor, and the title of his talk is The Value of Vascular Surgeons in Modern Healthcare. And, I know this to be true because it typically is not a very serious pancreas case unless I'm in the room, Dr. Del Chiaro is in the room, and several members of the vascular team and other pancreatic surgery members are in the room. So we fought many, many battles in the operating room and post-operatively together. So Dr. Malgor is a professor of surgery in the vascular division. He received his MD at the University of Taubaté in Sao Paulo. He's also recently received his MBA from the University of Colorado in 2012. He completed both general surgery and vascular training at Sao Paulo State University, and then decided to come to the United States and did a research fellowship at the Mayo Clinic, and then entered an integrated vascular surgery residency program at Stony Brook. He held a couple of faculty positions at academic institutions, but then we were able to recruit him here in 2019. Since then, he's really led many of the efforts in vascular surgery, both in the training arena and clinical arena, has led a lot of the safety and quality measures. He has over 100 peer-reviewed publications. He's an excellent teacher and excellent clinician. And again, I know this because I've operated with him many times in the operating room. So Dr. Malgor, we look forward to your talk. Thank you.
Thank you, everybody, for the opportunity. I think a lot of you in the audience know me for those reasons that Dr. Schulich said. I participated talk to a lot of people in the corridor. So I try to be a little bit fast here. So those are my disclosures from board of directors from Colorado Medical Board and other industry actually arrangements as well. So modern healthcare management ecosystems are very complex nowadays, and we know that. And about my talk is not as much scientific as genomics, but it's a little bit real in terms of what's going on in the system. So we have healthcare leadership and governance, we have workforce management, financial management. For this matter, we do have to keep the lights on and pay the bills. And population health management with preventive care, chronic disease, and social determinants of care of health, especially in vascular surgery when we have like a chronic disease like peripheral arterial disease that's very deemed to actually our system here. So the only issue for all of this beautiful actually talk for healthcare management, we have a productivity base or a fee-for-service model in many hospitals in the nation that cause actually a pressure on all the physicians that are involved in the care of patients for the productivity and for the service model. So not in common, we end up being called in the operating room, and the intraoperative vascular consultations have been studied by many actually centers in the United States because multiple times you just call vascular surgery, but then we don't sometimes have the credit that we deserve from the healthcare system in general. So this is a publication from Portland from OHSU that look at 8 years of 225 intraoperative consultations. The mean vascular RVUs were 30.9 RVUs per case. Why is that important? That is the amount of reimbursement that is generated when somebody calls vascular surgery. And we're going to actually talk why it is important to maintain this ecosystem and have everybody together as a team, just like, you know, Navy SEAL team, we have a team in the healthcare system. So in Portland, you have most of the cases were somewhat surgical oncology. You see portal vein, superior mesenteric vein actually reconstructions. This does not happen here as much because Dr. Del Chiaro usually does this part of the operation himself, but this is not common throughout the United States. And you see there's overlap of what the vascular surgeons provided. They don't go there only sometimes to put a stitch to stop the bleeding, but there's reconstruction, there's dissections as well. In Portland, almost 50% or half of the case was surgical oncology. So it's not uncommon also to get a phone call and say like, can you come to R23? Can you come to R39, 40? You know, 15, 13, 15 doesn't exist, but 12, 12B, 12A. So I said 13 on purpose. Sometimes a disaster. We got a call and then call vascular surgery to R13. So 6 intraoperative planned and unplanned vascular surgery in 3-year period. This is from USC, from Southern California. You see the mean RVUs for per cases is 23.8 usually. 56% of the consultations at actually a USC were unplanned, and 1/3 of those consultations were to control bleeding. The unplanned consultations, you know, the culprits here were urology and hepatobiliary transplant surgery, and most the planned ones were cardiac and orthopedics for spines, so you have more of an understanding and actually a heads up. This is a paper that was published in JAMA Surgery by the Northwestern group. You can see that they look at 299 patients, 12 different surgical specialties from 2010 to 2014, 212 elective consultations, 224 requests preoperatively. However, 78% were emergent and 19.3% were actually elective surgeries. And those elective surgeries were usually neuro or ortho spines. And the vessel that were injured the most for the emergent ones was the iliac artery or iliac veins that needed that vascular support. Intraoperative vascular assistance, when they look into the New Brunswick, actually the Huckers experience for 2011 to 2020, they had about 4 consultations per month. And that actually service, 30% were urgent, but the most of them, 70% were elective. This changes depending where we are in the United States. So 61% were advance notice, so there was a heads up. The number one type of operation was abdominal operations, followed by lower extremity. And here you see where the elective procedures usually have a heads up. It's orthospine, it's neurospine, and of course, urgent and emergent usually comes from TACs, from acute care surgery, for trauma in New Jersey in this case. There are several collaborations that vascular surgeons provide in the healthcare system. One of them is surgical oncology. This is a 7-year case study from Loma Linda with 21 oncologic cases. You see that vascular surgeons have been involved there with surgical oncology, with grafts, primary repair, ligation, or even exposure of vessels and masses at Loma Linda. This is a very interesting study that was performed at Duke University for 2 years. And now we're gonna start diving in a little bit on numbers. So they divided 2 groups, co-surgeons per specialty and service level cases, what iatrogenic complications, consultations for traumatic injury, and primary surgeon for non-vascular cases in 880 cases for 2 years. So Duke is very commonly regarded as the case that we have for collaboration. In those 2 years, the working reviews generated just for the consultations amounted to 18,000. If we think about, a regular, some vascular surgeon that working in academics that's provided 6,000 RVUs for salary support for he or herself, or themselves, you can see that this would be able to offset 2 or 3 vascular surgeon salary in the system. The only issue for Duke, you can see that 1/3 of the cases were done on holidays, weekends, and after hours. Sometimes people actually look at me in the corridor and say, like, you here again and again. You might as well be a tax surgeon because we are here late in holidays and all sorts of other times. And you see the amount of specialties that we can help there. But most of the cases are elective. I'm not trying to feel sorry for myself or for my team, but most of the cases are elective, but there is a huge push that we need to be on call and need to be fast here for bleeding and other things. But not only that, vascular surgeons are also called in all the ICUs, anesthesia, cardiology, some complications. And you see at Duke, like similar to us, they have a very heavy cardiac program and cardiology program at Duke. And you see there's cardiac catheterization disasters with blowouts in the groins and so forth. But also our favorite here, which was the ECMO cannulations and the code legs from the ECMO that we call frequently here. Because we provide the service and then there is some disconnect about the credits that we receive. The Society for Vascular Surgery queried and put together a paper in 2021 to show others what is the aspects of the credits that the vascular surgeon should get from the vascular surgery, from the healthcare system. Vascular surgery is a small specialty. We don't have 15, 20, 25 attendings, but we do have like this power actually in terms of helping and empower others and enable other services. So everybody knows there is a shortage of vascular surgeons in the US, and 1/3 of the hospitals in the nation might be hiring a vascular surgeon right now. I can just tell you that Pueblo needs 2 vascular surgeons, Colorado Springs needs 3 vascular surgeons, Cheyenne needs a vascular surgeon, and there's several other hospitals in the state and around us that are actively recruiting vascular surgeons. So this is just a case study for 6 months with the numbers that we already talked. Most of the cases that vascular surgeons are involved nationwide are spine exposures, cardiac, and hepatobiliary and surgical oncology actually collaborations. So this is the message the Society for Vascular Surgery delivered, that we sometimes are invisible to the hospital administrators, which makes very difficult to operationalize everything we do. And there is a profound impact on the hospital margin that we're going to be talking about, with the vascular surgeons can actually provide to the system. This is to say that this is not only in the United States, this is a publication from Australia showing vascular collaboration in surgical oncology and showing lower odds of vessel repair and reconstruction when a vascular surgeon is involved in the surgical oncology operations, and lower incidence of positive margins, surgical margins for surgical oncology in Adelaide in Australia. Another very common collaboration that vascular surgeons provide in the system is with podiatrists and foot and wound care. You see 3 publications in your left-hand side and how it plays out when vascular surgeons are associated with podiatrists. You see the working RVUs going up over the years. Everybody wins in this scenario. But the most telling graph there that you can see of your right-hand side at the lower part, you see there is a disconnect between the hospital contribution margin and the salary support provided. There is a gap between what the system gets for the care provided and the support that is allocated to the vascular surgery service. This was from University of Arizona in Tucson. You can see there is a gap there. So because of the gap and all of this discussion about what is the value of vascular surgery in the system, Joe Lombardi from Camden, New Jersey, from Cooper Hospital, he just moved. He put together what he called the X factor in vascular surgery, because it's not only we participate in the surgery, we do surgery, but there's several other spin-offs and downstreams from what the vascular patients can actually provide the system. And he calculated every single patient that came to the system, he tracked down all the CT scans that were ordered, all the vascular lab studies that were read by the vascular service and so forth. And he came to $10,786,000 for what was provided in those 3 years, and came to the administration and said, like, this is the amount of money we provide you in terms of hospital margin that we're not seeing in terms of like return for support. At Cooper, most of the aortic surgeries are done by vascular surgeons in terms of TVARs and descending thoracic aorta. So you see the aortic surgery is number one there, but the other service provider, like imaging studies, vascular lab consultations, are also important for those $10 million that they found at Cooper Hospital. So the X factor for vascular there was 1.66. So there is a multiplication factor for everything we do. It's not 1-to-1. So let's talk quickly about what is being done here and what we have. We don't have all the data like the other places right now, but I think this is a project that we initiating now. So I picked randomly 2010 as a division of vascular surgery. Several of you that have been here for more than, I should say, 7 or 8 years know that vascular surgery had significant changes with turnover and rebuilding of the faculty. There is actually a growing credibility and reputation across the region because we have a bigger team, more cohesive team. Increased collaboration with multiple service, establishment of our outpatient headquarters, or that we called Outpatient Basic Laboratory, or OBL. There's nothing about basic science, it's just an outpatient setting. We expanded to Cherry Creek. We potentially starting at the dialysis center at Azura, establishing the Highlands Ranch in 2019, and the training programs over the past, I should say, 12 years started. We started the Vascular Surgery Fellowship in 2013, and the residency we started in 2021. This is our headquarters. For those that don't know, this is also to inform. We have our outpatient clinic behind Panera, across the sky bridge from the street bridge from the Children's. We started in 2020 as a matter of necessity during the pandemic. For multiple reasons we talk quickly here. We try to personalize and timely provide care to our patients, amplify our capabilities, because if we expand, as you can imagine, there is no place to put eight or seven vascular surgeons at the Heart and Vascular Center here in terms of space. We try to increase the revenue. We manage, the vascular surgery division manage a business manager, 2 full-time nurses, 3 medical assistants, a front desk specialist, and a dedicated technologist to do the vascular studies. We have our own vascular lab at this facility. There are opportunities there that we actually explore. We do vein procedures there. We do CRM procedures such as fistulograms, placement and retrieval of IVC filters, angiograms of the legs, arms, and other procedures as well. And there's daily vascular surgery clinic in conjunction with the Heart and Vascular here, because we needed a place to put the vascular surgeons. It is an intensive call schedule, as I was joking around actually the other day, saying like, you know, sometimes we are more here than other people can imagine. We have 77.5 physicians, FTEs. Every 30 days, usually we are called in to see patients or to operate. Our OR staff is pretty overworked. There is 9 hours outside of the block time that our team has to work, which doesn't increase satisfaction. Late rooms start cases are 201 in the fiscal year 2023. and fiscal year 2024 were 198 actually late starts for vascular surgery. The work RVUs are increasing over time as expected. If the faculty increases the work RVU, and the amount of work has to increase to support the faculty, but we think there is actually room for improvement there. So there are challenges and there are opportunities for us as a collaborative actually service. The wound care here is a little bit fragmented. We don't participate a bunch on the wound clinics. The limb restoration is led by orthopedic surgeons here instead of vascular or other vascular specialists. We have no access to the cath lab or IR suites at the University of Colorado Hospital. So we don't have the ability of doing our angiograms in the hospital. So we had to find another way to do that. So we opened the OBL. There's only one hybrid main OR. For those that know vascular surgery as a modern actually specialty, 60% of the cases need some type of radiation at this point. And we only have like one OR, hybrid OR for 7 to 8 busy vascular surgeons in our practice now. We have insufficient space at the Heart and Vascular Center for 8 vascular surgeons, as you can imagine. Right now, we can potentially try to accommodate, but our outpatient facility is helping us to accommodate all the vascular surgeons and become productive. And we have a decision tree system. Sometimes the consultation comes for vascular surgery or cardiology and gets misplaced. And I have a patient that tomorrow that I have to see for a heart murmur that I have to cancel because the decision tree was not that perfect. So we plan ahead. We plan ahead for more collaboration for wound care, foot and ankle surgeries as well. We're trying to expand our footprint in the metro region. We're trying to create multidisciplinary clinics, especially the aortic service here with cardiac is very well structured. We have always a conference every single Monday morning. So thoracic outlet is another point that I wanted to emphasize that we do quite a bit here. We're trying to expand in vein treatment capabilities as well in an outpatient facility. We have to curtail overhead expenses, congregating services, because it becomes really expensive to keep the lights on if we don't have as much support sometimes. Exploring outreach clinics opportunities within the metro area. For those that don't know, we're limited by some boundary lines from the north and the south by the system, and we try to work in the metro region, which is somewhat saturated. And we try to strengthen relationships in the local business and also regional business. We have several referrals coming from Glenwood Springs and the mountains as well. This is just some representation. I did not pick any other person actually surgeries. Those are all my surgeries. You see on your left-hand side, there's a cable repair with a patch from urology, a case that I did with Dr. Moroni. Then in the middle, there is actually a type 3 thoracoabdominal aortic aneurysm and an open thoraco that I did with Reese. And then in the other picture, Dr. McCarter is sitting there. I can see that. He probably remembers that case. It was a leiomyosarcoma of the inferior vena cava that we had to resect the inferior vena cava, replace with a PTFE graft, and reimplanted bilateral renal veins to the graft. I'm just happy to say that the patient is disease-free, and the follow-up now probably like 1.5 years out. We also do research collaboration. So vascular surgery is not those soldiers that come to help in the operating room, but we also publish this. Those are 3 publications for last year with plastic surgery that we have done. There's some of the aortic, you can see Dr. Reese's name there too. There is some with orthopedic surgery and a vast majority with urology as well as research collaboration. So in terms of take-home message, to allow some time for questions, I believe the vascular surgery services are critical for the system. There is an X factor that a lot of people ignore, and we become underestimated because those vascular surgery patients will need reintervention, will come back, and will need more imaging studies that multiply the power of vascular surgery in an academic center. We should protect and promote vascular surgery. It's a strategic move. We do not want the vascular surgery division to implode again and have to rebuild it. So it's important, it's strategically important to work as a team and collaborate with each other. We should expand the service and the collaborations. And our specialties, that's the most important actually message of my talk. Our specialties should collect data and have this X factor to increase negotiation power with the system, to be more visible and having a better negotiation at the table in terms of support. This is the cerebrovascular surgery division in 2025. Thank you.
So we have a couple minutes. Questions or comments? So I'll start. What do you think will happen with Intermountain and some consolidation of and even splitting up of some other healthcare systems in Denver and in Colorado? How do you think that affects us? And in particular, the vascular surgery services?
I think these consolidations in Intermountain will take a piece of the market and will make difficult for us to tap on some of the clinics that they might be expanding and buying, and we will not have access to those patients. So it has to be a concerted effort from our system to start to refer internally and making sure there have been some incidents that we saw some services at Anschutz referring out of our system to HCA systems or other competing systems. I think this is going to make our life even more difficult, especially because Intermountain does have some capability of hiring their own and saturating even further the system that we live in here. So I think we need to secure those referrals and those practitioners around us.
Yeah, and I think there's also, I mean, I've seen some vascular services in Denver implode too. And I think there's some opportunities there to pick up. Dr. Jacobs.
Rafa, that was a great talk, and it reflects a lot of discussions that we've had within our division and also with hospital administration. And I think we're not unique. The fact that this has been published somewhat specifically in vascular surgery, the value being not really recognized to the system. And I wonder if you think this is how we've evolved as a specialty over the last 20 years to, do so much really what is related to vascular. Trauma does less, general surgery does less, a lot, and we cover, the endo and the open aspects. And so we've changed the distribution of care, but maybe not been recognized in the big picture of a way of a distinct specialty. Your comments on that?
I think sometimes just to acknowledge Luis Morales, our research fellow, is here too, and he helped, we looking into a systematic review for this topic. But just to answer your question, there is not much understanding sometimes what we do. There's so much overlap between us in interventional radiology and interventional cardiology that becomes difficult. I think we should promote more vascular surgery. And it has changed, Don. Sometimes people come to me, it's like, so do you do a IVC filter? I feel like I don't feel offended, but I'm shocked. Which you say we've been doing this for decades. And sometimes people ask, do you do embolizations? I thought even IR did that. Why can't you do the embolization? We do embolizations too. So I think it's a little bit of a fault on our side that we did not publicize, we did not market ourselves. And I think we should market better our services to increase our visibility in the healthcare system over time.
So we're at 8. Thank you very much. I think there's a lot of food for thought here and ways to really build this program. Everyone have a great week and thank you.